In medical care, prior authorization was originally intended to ensure patients received appropriate care that was in line with tested methodologies. Today, prior authorization has become a dreaded term, often signaling delayed care and undue financial burdens posed to patients and care providers alike. In some cases, the process of prior authorization has actually put patient lives at risk. What changed over time? Most of all, what can be done about it now? Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly with AHA Communications. With me today are two colleagues who are very well informed about the hazards and pitfalls of the overuse or misuse of prior authorizations in the course of patient care. Terrence Cunningham directs AHA's Administrative Simplification Policy, and Andrea Preisler is Senior Associate Director with the same office. So, to get rolling, I guess I would start with this. Let's start with how prior authorizations, I guess you could say, have gone off the rails. Many believe that they're no longer serving their original purpose. So, my question to both of you is, how are prior authorizations typically being used now?
Thanks, Tom. I would agree with your assessment that these have gone off the rails a bit. As originally designed, prior authorization was supposed to be for controlling situations where there was a high prevalence of misuse or a variance in treatment protocols or patterns, or where you were dealing with extremely expensive care. Today, prior authorization has grown exponentially, and it seems to be being placed on anything, including a high cost procedure, all the way down to something like a simple drug such as insulin. And so I think the concept of going off the rails is important because I think what's happened is this tool, which was built to really control what would be outlier costs or situations where you've got a need to make sure you can control for outlier costs, has really turned into something that's really a barrier to care frequently. And so it could, today it seems to be being utilized to delay or even dissuade patients and providers from pursuing certain treatments. Essentially, it's placing a barrier in the way of obtaining care in the hopes that it might result in treatment abandonment. And that's me speculating, but I think the way in which it's manifest now has really gone far beyond the way it was initially envisioned. And I think that's where we're concerned with how prior authorization is being rolled out, because it's no longer a cost control measure necessarily to kind of supplement and make sure that you're giving appropriate care. It's really serving as more of an obstacle oftentimes to appropriate care.
Andrea, why do you think that has happened? How did it stray from its original purpose and to morph into what we're looking at today?
Sure. I think as Terry mentioned, it started off as a cost-cutting measure, right? So I think that payers have just little by little been, chipping away at that and using it to really impact patient care in a negative way.
Is it that calculated, do you think? That deliberate?
I can't say for certain. I would just say the way in which it's rolled out has far exceeded the way it was designed. And so whether it's calculated as to we need to figure out a way of preventing, a diabetic from getting his insulin, or if it's just we're spending far too much on insulin and they're not providing the appropriate level of consideration to say, wait a minute, this is not an area where there's a whole bunch of misuse. Yeah, we're spending a lot because we have a lot of diabetics on our plan, but that's not something we should be trying to control. So I think whether there's any malicious intent, I would say that there certainly could be in certain areas, but overall, I think it's just they're placing financial considerations above the overall patient impact. And so I think patient impact is being underappreciated when they're making these decisions to place things on prior auth.
So I think, if you're denying or delaying insulin to a diabetic patient, it really doesn't serve much of a cost-cutting measure, but seems to have no purpose but to harm the patient and dissuade patients from seeking or continuing needed treatment.
And what's been the fallout from this shift in attitude, I guess? Specifically, what kind of burdens do prior authorizations place on healthcare workers that have to deal with them?
Yeah, prior authorization places a significant burden on providers, and numerous studies cite it as the #1 burden on providers. So, for example, a recent American Medical Association survey, physicians and their staff reportedly spend about 2 days per week completing prior authorizations. And 88% of physicians describe the burden associated with prior authorization as high or extremely high. So it not only adds cost to the system through inefficient staff time and information technology investment needed to comply with these insurer policies, but it's also a significant contributor to workforce burnout. And then I think it's really important here to highlight the effects that this process then can have on providers when their professional judgment is constantly being called into question, oftentimes by someone without the requisite medical knowledge, without knowing the patient, without examining the patient. And then the providers are seeing how this downstream negatively impacts these patients who are unable to obtain timely care.
Yeah, I was thinking that one of the things among among a number of things that I think a patients would find concerning about the state of affairs today is what Terry referenced a minute ago, and that's the questioning of the use of drugs that would have been taken utterly for granted, some years back. Insulin, for example, is a good one, but treatments that are universally accepted are not necessarily given the green light without some questions and some obstacles these days. Is that correct?
Yeah, I mean, I think that's unfortunately frequently happening where, again, things where there are not this widespread variance in terms of provider prescribing patterns, where you might just have a lot of beneficiaries on your health plan that are in need of this particular treatment. Just because there's a lot of people needing a treatment, that's not a reason to place a cutting measure in place. And so I think a lot of providers, really the frustration is just that there's not any gray area that they're operating under. It's a very clear need for this patient to obtain this particular treatment or drug. And by requiring prior authorization and I'm sure we'll talk more about this specific later, but when requiring prior authorization, which is an extremely non-efficient process in terms of obtaining approvals, it's going to delay care. So you're really all you're doing is putting up a temporary roadblock to a patient getting care that at the end of the day, they're going to get because they need to, and it's completely medically indicated for them. But by placing this prior auth on it, you're not necessarily preventing a patient from getting an unnecessary treatment or ensuring that prescriber reporting habits are completely in line. You're really just delaying your need to pay for this. And unfortunately, there's a couple ways that could manifest, which, again, if we're thinking about the payer's bottom line, could be a windfall for them, right? If I go to a pharmacy and I need a pain treatment and my pharmacist says, you're going to have to wait a few days, I've got to wait on prior authorization. The patient might say, you know what, I'm going to pay out of pocket for that. Well, there you go. The health plan doesn't have to pay for that, but the patient does. Or it could be, things where a patient is going to say, forget it. I don't have the time to be going back and forth to this provider. If I can't get the treatment now, I'm just going to skip it altogether. And I know that sounds extreme, but actually, if you looked at that same AMA survey that Andrea cited earlier, I think it's something like 83% of physicians or 82% of physicians reported having patients that have abandoned treatment as a result of them encountering prior authorization when the treatment was initially prescribed or was sought. And so I think there's some financial considerations beyond making sure that it's appropriate that might be in play, but at the end of the day, this is really just interfering with appropriate care, which is obviously our extreme concern here.
That's an astonishing statistic and a very alarming one. As I understand it, another complicating factor is if you, as the care provider, are dealing with a dozen different insurers, you're probably dealing with a dozen different systems for getting that prior approval, if you can even do that. Just the lack of uniformity, the lack of standardization. Can you talk about that a little bit, Andrea, and what the effects are?
Sure. Yeah, these plans, as you mentioned, vary widely in these processes. So everything from what procedures and treatments they apply prior authorization to the different documentation required to then, support this request for treatment or a procedure. And providers and their staffs need to ensure they're following the right rules and processes for every individual plan. So, this could be 12, it could be many more. So not to mention that prior authorization criteria is constantly evolving. So providers and office staff have to then consult, the insurer's website or a printout or whatnot to determine whether any part of the proposed care plan requires prior authorization and what documentation is required. So oftentimes this is a manual process of staff culling through these lists to see what insurers will and will not cover in a given month. So again, I just want to reiterate that this process is specific to a patient's health plan. So some insurers offering plans that feature different prior authorization rules for the same services.
Yeah, got it. I think we've spent a few minutes here on what the problems are and what providers and administrative staff face every day. So let's shift gears a little bit here and talk about what we can do to ensure that prior authorizations actually work the way they were intended to work. What are some steps that you'd like to see taken to address this problem?
Sure. I think standardizing is a great first step. I don't think it's the solution, but I think it's certainly part of the solution. So we're really interested in developing a technical solution to automate and standardize prior authorization requests and responses. And within that technical solution, we can build in each individual plan's prior authorization criteria and have the prior authorization request and any supporting documentation needed to support that request be fully automated. So if this is designed correctly, the standardization could really help mitigate some of the burden that providers experience. And importantly, if it's carefully tailored, it could go a very long way in expediting the prior authorization process and therefore get rid of some of these care delays that patients are currently experiencing.
One thing I'll make sure to highlight as we talk about standardizing, and Andrea touched on it, standardizing is a huge step. It could really make an enormous difference. But I think too frequently in this space, it's talked about as the cure-all. And I don't think necessarily by standardizing this that you're eliminating all of the issues that that clinicians and hospitals are experiencing with prior authorization. For one, prior authorization is inherently going to be an obstacle to care. It's by nature, it's going to require the verification of a clinician's medical judgment by someone in the health insurer's space. So it's not necessarily that standardizing that is going to address this issue. And I think an important thing to realize is standardizing the process is great, but if you're standardizing a process that is inherently flawed, or if you're standardizing a basic program that's got inherent flaws in it, then it's not going to address the issue. And what do I mean? What do I mean by that? Are the coverage and medical necessity being utilized really appropriate? So we talked about this earlier. Are they appropriate? Are they clear? Is there a sufficient level of transparency as to what is going to be subject to prior authorization so that when we're planning care up front, is it going to be upfront? But also, is it appropriate? Is the medical necessity criteria being used? Is it appropriate as well? One of the issues that was highlighted recently in an OIG report, that I say OIG, I mean the Health and Human Services Office of the Inspector General. They did a report where they looked at Medicare Advantage plans. And again, Medicare Advantage plans are where commercial health insurers are essentially providing Medicare coverage to our seniors. And their report essentially determined that the prior authorizations being utilized by these health insurers are frequently denying care that should have been approved. So you can't automate a process where they're basing a prior auth decision on flawed criteria. And so I think we definitely need to fix the process, but we also need to make sure that the medical necessity criteria being used is appropriate. We also need to make sure it's being applied appropriate. We can't just keep adding volume of services that have prior authorization on them. We need to get back to how it was envisioned and how we talked about at the beginning of this call, that it should really be controlling care that has a history of misuse or extremely costly care where it could be impacting. And so I think there's a solution can be ensuring that it's only applied where it's absolutely appropriate. So what situations beyond what I've discussed could that entail? It could be such things as the concept as gold carding. Gold carding is a concept that has been getting a little bit of steam in certain states and in certain circles where clinicians, if they have a history of frequent and regular adherence to a health plan's prior authorization criteria, that they would be exempt from having to seek it. So it would essentially be if, whatever percent, let's say 90% of all of their prior authorizations being sought are approved, then they shouldn't have to be forced to go through the prior authorization process. And again, this speeds up the care for the patient and it eliminates a lot of that administrative headache that Andrea discussed earlier. There's also things such as making sure it's not applied to situations such as where there's a risk sharing agreement where health systems, I know this is a new kind of model of payment that's being considered. And I think if a provider is willing to take on some of the risk involved in care, the financial risk involved in care, then they already have an incentive to ensure that they're providing the valued care. And I don't think prior authorization is appropriate in that type of situation. And so I think as we talk about prior authorization, unfortunately, I think the industry is very focused oftentimes on how do we standardize this. And while that's good, I think there's a lot of, it's a broader subject matter. And I think standardizing is only one step that has to occur of many that really needs to address this and make sure that patients are getting the care they need.
We need to be working on many fronts at once.
If I can just make one more point about standardization, again, I do think it's a great step. I think it's part of the solution, but building and deploying this technical solution will take a lot of time and a lot of resources. And not all providers will have the time and resources to implement these solutions.
Yeah, and that sort of leads into, I think, my final question. As an organization, AHA has been very vocal for some time about these issues, sort of laying out what we see as the problems and possible solutions. In your opinion, question for both of you, are there any signals or is there any reason to believe that the industry is starting to listen, that will be any kind of a shift or turnaround, or are we just kind of stuck in the water on these issues at this point? How do you see it?
I think it'd be naive to say, oh, this problem's going to go away really quickly, but there are signs that our advocacy is working and that it is getting some of the traction by those in positions of need to really start bringing about some of the changes we're seeking. One example of this is recently in the Senate and the House, there's been a bill that has been going through called the Improving Seniors Timely Access to Care Act. It was recently marked up and uniformly approved by the Ways and Means Committee. And this is an act that is designed to impact prior authorization in the Medicare Advantage space. And again, I talked a little bit about that before, but our members have reported the Medicare Advantage space is really just an area where there is a whole bunch of problems with prior authorization, and it's where a lot of their resources are spent trying to navigate on behalf of their patients. What this bill would do, it would reduce some of the time that health insurers are allowed to consider or come to a determination on a prior authorization that is submitted. Again, that would speed up patient care. It also requires the secretary to establish an electronic standard that Andrea had just spoken of. It also gets rid of the concept we kind of call as the black box prior authorization criteria. And this is where if I'm a provider and I need to seek prior authorization for something, if I don't know exactly what information you need as a health plan, it's going to be difficult for me to make sure that I satisfy and send you all the information you need. And that's a frequent problem. A lot of health plans don't share this type of information. And so this bill would require more transparency in that space and to also develop a process to get towards real-time prior authorizations. Again, something that theoretically could be submitted and you could get a decision while the patient is still in your office. So that's one avenue. Another that we're closely monitoring is CMS seems to have taken some interest in this. And what I mean by that is two fronts. Recently, there was a request for information in the Medicare Advantage space where CMS sought information as to how they could improve prior authorizations and figure out ways of preventing it from delaying or providing obstacles to patient care. And so we're in the process of providing our feedback on that, but it's just kind of a sign that CMS is hearing some of the things we've been talking about. And also, there was a rule that was released in late 2020 by CMS, and it was to standardize. It was, again, to standardize and create a standard prior authorization process. It was put on hold or delay as a result of the administration shift, but we're hearing signs that it is going to come out again soon. Initially, that rule was extremely limited in scope, and it only applied to Medicaid plans, CHIP plans, some exchange plans, some of the other federal-based plans, but it didn't apply to Medicare Advantage, for example. And so that was one of our comments as to why we were concerned about it, because a prior authorization standard only works if it applies to a large scope of your patients, because if it doesn't apply to enough, it's not going to be worth a provider's time in investing to only have a solution for a small percentage of your patients. And recently we've seen in what's called the unified agenda that the agency's put out that CMS is planning to re-release this rule, but there's signs that it might now apply to the Medicare Advantage plans, which is, again, was a really big part of our advocacy a couple of years ago. And so I think that's another way in which it seems like people are hearing us. And beyond regulators and those kind of decision makers that would have to usher in a kind of widespread industry need, there's also been plans that have been testing and really trying to figure out how to eliminate some of these burdens. One example is we've seen from an integrated system with a provider-led health plan that has really been working with their clinicians to figure out ways to eliminate prior authorizations where they're not serving the purpose that they would potentially be designed to do. And so I think the more health plans and the more there's this ability to figure out, to acknowledge that this could be getting in the way of care, and we need to rethink, are we applying this to the right services? It's really meaningful to see some of that. So I think all of that are some ways in which this is really achieving some change in the space, or at least makes us hopeful, and it makes us have the appetite to keep pushing and hopefully get this under control sooner rather than later.
Got it. Andrea, you have the final word.
Oh God, big shoes to fill. Well, I think I think Terry pretty much just nailed it.
Okay. I want to thank you both for your time and your expertise and sharing your thoughts about a really important problem that I think patients are aware of, but maybe not to the degree that they ought to be. So, thanks for identifying what's going on and talking about some possible solutions and momentum building to fix it. So thanks again for being on Advancing Health, and take care.